So Dr. Shonka is, again, not unfamiliar to us. So she's an associate professor in oncology and the hematology division in the Department of Internal Medicine here. He's, I think, one of the few, or the one, fellowship trained neuro-oncologists here, definitely taking over a lot of brain tumor patients in the state. She's also leading translational and clinical research, and particularly interested in developing some specific mouse model of glioblastoma, specifically the EGFRV3 mutant type, and served for PI for many trials. So she's going to give us an update on the immunotherapy in glioma, which is really a challenging topic and future topic for the next decade. Okay, Dr. Shonka, here's all yours.
Hi, thank you very much for the kind introduction, Kevin. And now that everyone's been impressed, can you actually see my PowerPoint in the format it's supposed to be in presentation, or are you seeing my view?
Yes, it's in
presentation view for you guys. Okay, great. All right, so a lot to get through in 20 minutes, but I will do my best. So I wanted to do an update of immunotherapy in glioblastoma as it currently stands. This is obviously a very hot topic in the media and in cancer in general, with all of the great strides that have been made in melanoma and lung cancer and GU malignancies and so on and so forth. So a little bit about how that applies to where we are right now in the glioma world. So at the end of this, hopefully you'll be able to discuss some reasons why checkpoint inhibitors unfortunately haven't so far been very effective, understand some of those mechanisms of actions and how they might apply to glioma study, and then describe ways in which immunotherapy may actually end up having a role in the clinical treatment of gliomas. So a little review of checkpoint inhibitors, which a lot of you are yep.
So sorry to interrupt you, but your slides are not advancing.
Oh, okay. Oh, that's interesting. Thank you. Okay, now they are, right?
Yes.
Yes.
Okay, thanks, Michelle. So a lot of you know this very well. So we have PD-1 inhibitors, programmed cell death 1 inhibitors as listed. And then there are CTLA-4 inhibitors, PD-L1 inhibitors, and then the newer ones that I'm going to address a little bit in a couple studies are IDO1 inhibitors. So these actually improve NK and T cell function. And then also something called TIM3 surface receptors. These are on CD4 and CD8 cells. So we'll talk a little bit about that later. I'm going to go through this kind of quickly. So the rationale for PD-1 and PD-L1 inhibitors in glioblastoma is that, you know, really provocatively, initially when we started looking at this, it's expressed in 88% of newly diagnosed glioblastoma and 72% of recurrent glioblastoma. So this is quite exciting. Specifically, it was really high in the mesenchymal subtype, which is typically more aggressive of a tumor than the other subtypes of glioblastoma. However, there are a lot of different things that make glioblastoma not a very great microenvironment for this. So one of these is anergy of the effector T cells to block tumor-specific antigens. The tumor microenvironment T cells express multiple checkpoints, so blockade of just one is really probably not going to be sufficient. There are rare tumor-infiltrating lymphocytes as opposed to in other tumor tissues, other cancer tissues, and these tend to be suppressed by glioma secreting TGF-beta and IL-10 both. Furthermore, these tumor-infiltrating lymphocytes express immunoinhibitory molecules CTLA-4 and PD-1. As I mentioned above, there's multiple checkpoints. Oftentimes, they'll co-express PD-1 and TIM3, and together that represents a pretty exhausted CD8 positive cell phenotype. So furthermore, you can see lymphopenia specifically caused by radiation therapy. Circulating lymphocytes actually end up receiving, interestingly, a mean dose of about 2.2 gray. And temozolomide, furthermore, not to just blame my friends in radiation oncology, but temozolomide can decrease your CD4 count for up to 12 months. It can reduce the CD8 and the NK cells as well, and it increases the presence of T regulatory cells. So a lot of hurdles. Furthermore, glioblastoma has both intrinsic and adaptive resistance. So intrinsic, what do I mean? It means that less than 10% of these patients that have glioblastoma are going to respond to immune therapy thus far. This shows you here on on the left that melanoma is really somewhat the poster child for having less intrinsic resistance and less ability to develop adaptive resistance too, whereas glioblastoma is in the upper right hand of this diagram. So there's a high level of P10 mutation in those patients that we see specifically not responding. If you look at single cell RNA profiling, that actually shows that's from tumor cells that overexpress CD44. There are few tumor infiltrating lymphocytes and more clustering of tumor cells also. And responders to the anti-PD-1 therapy had an enrichment of their MAPK alteration, specifically PTN 11 and BRAF. Whereas in the adaptive environment, what we've found is a loss of response associated with loss of immunogenic neoantigens, and then a loss of mutations that generate those neoantigens. And I'll bring that up when we're comparing this with colon cancer in a few slides. So what have we done so far? So there's an adjuvant studies for glioblastoma and recurrence, both Checkmate 143 and Keynote 028, looked at nivolumab and pembrolizumab in the adjuvant setting, first progression after chemoradiation therapy. And initially it looked promising, interestingly, the nivolumab group alone. But unfortunately, in the phase 3 study, that looked at the cohort specifically looking at nivolumab versus bevacizumab, there was no advantage at all. Pembrolizumab, similarly, we do not see any significant survival advantage, and the overall response rate was a pretty dismal 4%. So what about neoadjuvant? So this has been much more enticing. So there was a single arm phase 2 neoadjuvant study of Nivo followed by adjuvant nivolumab versus those who only received it after surgery. So they took 27 recurrent, 3 newly diagnosed. There was no clinical benefit in the recurrent glioblastoma that they found, but in the newly diagnosed glioblastoma, they had 1 patient who had a 33-month progression-free survival. So not overall, but progression-free. So that's really pretty great in a group of patients that typically has a median overall survival of somewhere of about maybe 18 months. What they found in the tumor tissue at time of resection was enhanced transcription of chemokine transcripts, higher immune cell infiltration, and some augmentation of the T cell receptor clonal diversity among the tumor infiltrating lymphocytes. In the recurrent resectable glioblastoma, this study looked at separating out 16 patients got neoadjuvant and adjuvant pembro versus 19 who just had adjuvant pembrolizumab after surgery. And you can see the difference there of 13 months overall survival. Again, this is a recurrent group versus 7 months in the adjuvant pembrolizumab group, which really compares relatively similarly to historic bevacizumab results. So they found in that tissue upregulation of T cell and interferon gamma gene expression in the receptors, also increased tumor infiltrating lymphocytes and peripheral blood clonal T cell expansion, decreased PD-1 expression on the peripheral blood T cells too. Here is also very important clinically for us to understand is that, interestingly, the dexamethasone dose in these studies was not correlated with survival. And that's analogous to what we found when we have to use steroids for side effects of this in other malignancies. This is kind of a sideways waterfall plot of what they saw from that same study I just mentioned, so I'm not going to take too much time here, but here you can see again, the neoadjuvant group had much better overall survival. So why do we think that is? So the proposed mechanism is that this neoadjuvant PD-1 blockade actually activates those tumor infiltrating lymphocytes, which increases interferon gamma related signaling and decreases the tumor cell cycle related genes. The adjuvant PD-1 allows tumor specific T cells to kill those residual tumor cells then and create memory cells. Whereas in the adjuvant only group, surgery occurred before the checkpoint blockade release. So because then you have reduced antigenic tumor burden, the T cell receptor modulation wasn't as robust. You had less or fewer T cells activated, and so the tumor grew more quickly. So combining radiation with immune checkpoint inhibitor also has an interesting rationale for doing this. We know that radiation therapy will enhance antigen expression on the tumor cell surface, and that increases the effector T cell function. We know this from what we talk about as the abscopal effect and other malignancies. So in this figure, I want to show that radiation therapy plus the anti-PD-L1 increases the T-cell mediated tumor death. So alone, this is not cytotoxic, but combined, you actually have MHC upregulation and FAS, which is apoptosis antigen 1 is the other name for that, on these tumor cells, and that increases the susceptibility then for that T-cell mediated cytotoxicity to lead to further cell death. So in further rationale for this, Zhang and colleagues looked at dual PD-1 blockade with radiation therapy and murine glioblastoma to increase the survival of those rodents for two times greater survival. They did another one where we blockaded, now here I mentioned that TIM3 receptor as another pathway of immunosuppression with PD-L1, and stereotactic radiosurgery, a PD-1 inhibitor and stereotactic radiosurgery together. So your dual blockade of TIM3 and PD-1 inhibition along with stereotactic radiosurgery, they had 100% overall survival of murine glioblastoma, seems too good to be true. What they found was increased CD8 Tregs and increased pro-inflammatory cytokines as well. Checkpoint 143 did show acceptable toxicity in the arm of the study where the cohort looked at nivolumab plus radiation plus temozolomide. They also had another cohort that looked at radiation plus nivolumab specifically for unmethylated patients. So I'm just mentioning that we know that the toxicity is acceptable for that. There was another study, ATIM 18 in recurrent high-grade glioma, so grade 3 and 4. They looked at pembrolizumab with hypofractionated stereotactic radiosurgery given at 30 gray and 5 fractions, along with bevacizumab. The overall response rate continuing at greater than 6 months was 53%, and the 12-month overall survival is 64%. So again, there's a good rationale to do this. They do appear to have some synergy. Here are some studies of immune checkpoint inhibition and radiation that I really don't want to go over in interest of time, but just wanted everybody to be able to have for reference with this presentation later. So this is one thing that's been really frustrating for me. All of my colleagues, other than those who treat a lot of triple negative breast cancer, have basically found that tumor mutation burden is a surrogate marker of response to an immune checkpoint inhibitor. Sadly, as presented here in Nature Genetics, this is not true for glioma. So you all can see that this right here is glioma, whereas everything else was to the left of this line, other than this is specifically breast cancer, like kind of average here, but this is the triple negative breast cancer. So tumor mutation burdens out of 10,000 gliomas average only 2.6 mutations per megabase pairs, okay? And there's a really big range for that. But some of you may know that pembrolizumab was recently approved by the FDA for anyone who has any malignancy agnostic of the type, purely based on if you have greater than 10 mutations per megabase pair. So glioma in general and glioblastoma is very low for this. Only about 5% of all of these tumors are going to be hypermutated, which also, again, kind of forms into that tumor mutation burden result that we get from next generation sequencing when we do that. Most often that's going to be in high-grade tumors, and it's much more likely in recurrent tumors, which we'll talk about why that's still not a surrogate marker of this being a better thing to do for patients. There are two pathways to hypermutation. There's de novo, which is associated with mismatch repair genes, such as those in like Lynch cancer patients, Lynch syndrome, colon cancer patients. And then there's constitutional. And then the acquired are those that are DNA polymerase defects. And that's what we see after someone has had cycles and cycles of temozolomide. So again, not really a marker for response. This kind of talks about everything that I mentioned already. So I'm going to kind of pass through this, but first bring your attention to the bottom right-hand corner, the overall survival curve. You can see that whether tumor mutation burden is low or high, there's really not a significant difference in survival. So this is the example where it compares colorectal cancer to glioma. So in colorectal cancer, we have these mismatch repair deficient cells before we even treat them. And then we drive more clonal mutations along the way, and specifically some subclonal mutations with treatment. Whereas in glioma, you have MMR proficient cells and a pretty low mutational burden to start with. And then those mutations that we drive by giving temozolomide are largely going to be these non-antigenic subclonal mutations. And so we just don't really improve survival based on using the immune checkpoint inhibitors here in these kinds of situations. So again, just kind of a summary, a little bit of determinants of response to checkpoint inhibitors. So the things we know are not a determinant. So the glioblastoma subtype is not correlated with response. Tumor mutation burden is not. Mismatch repair deficiency is sadly not correlated with this, nor is steroid dose, and that's kind of a positive thing for us. PD-L1 expression is also not. Things that are correlated with response, all we found so far molecularly is enrichment of MAPK alterations. So, and you can see again at the bottom here, this was a single agent pembro in a variety of non-colorectal types with deficient mismatch repair within the Keynote study. And you can see that the 13 brain cancer patients had 0 overall response rate. So now to get to a little bit of some of the ASCO updates from this summer. So they looked at the impact of mutant IDH, specifically mutant IDH inhibition on DNA hydroxymethylation, tumor cell function, and tumor immune microenvironment in resected mutant IDH1 lower grade gliomas. So what they did in this study was they looked at using neoadjuvant ivosidenib, which is an IDH1 inhibitor, as well as vorasidenib, which is both an IDH1 and IDH2 inhibitor. And they found that that reduced 2-hydroxyglutarate in tumor tissue, which makes sense knowing what that does within the Krebs citric acid cycle. Those who had a suppressed 2-hydroxyglutarate that was significantly suppressed, they did have increased CD3 and CD8 positive tumor infiltrating lymphocytes seen in their tumor tissue. So that's one way that future studies can look at combining an IDH inhibitor along with immunotherapy and perhaps having more meaningful response from that within these tumor tissues if we've already increased the CD3 and 8 populations. Another looked at a first-in-human CAN3110, which is an ICP, which is ICP 34.5 expressing HSV1 oncolytic virus, and they use this in patients with recurrent high-grade glioma. So CAN3110 maintains a copy of the HSV1 gene that is under transcriptional control of the tumor-specific promoter for nestin that drives more robust tumor-selective replication. It also replicates in malignant glioma cells far above the ICP 34.5 gene deleted viruses, which is what TVEC is in melanoma. So it's similar to a melanoma TVEC vaccine, only this has had further modification of that gene so that it actually replicates in the malignant glioma cells. So they did this intratumorally. They injected recurrent high-grade glioma patients. It was really well tolerated. No one had encephalitis or meningitis. And so this is moving on to further studies. Molecularly, what they found was this was associated with high-level markers of immune activation, and they also found persistent viral antigen as well. So this is moving on to further study. There's a randomized phase 2 study of nivolumab with either standard or reduced bevacizumab in recurrent glioblastoma. They had 90 patients that were in first recurrence, and they randomized them to standard bevacizumab, which is 10 milligrams per kilogram every 2 weeks, with pembrolizumab versus a lower dose bevacizumab at 3 mg per kg every 2 weeks, again with pembrolizumab. There was no difference in overall survival at 1 year in these two groups. This is pretty similar. One of the things that they found was that the standard dose bevacizumab patients did have decreased myeloid-derived suppressor cells and an increased inflammatory response gene signature, although it didn't actually translate to any significant difference in these two groups. So again, we haven't seen a lot of we haven't really seen any positive data using this alone in the adjunct setting. So another study looked at comparing immune and microenvironment between primary lung tumors and paired brain metastatic tumors. So I find this interesting because a lot of what we've learned in how to treat our tumors has come from the more common tumors outside of the CNS as well. So what they found was that in the brain, you do have a very different microenvironment. So not only for our primary brain cancer patients, which is my particular interest, but also in brain metastatic patients too, they see some similar issues. So in the brain metastases for these 43 matched primary and brain met samples, they saw reduced TILs. Significantly so. They saw fewer activated CD8 T cells and effector memory CD8 cells in all of the tumor infiltrating lymphocytes. Again, that was significant in its p-value. They saw lower scores of immune-related signatures, including the major histocompatibility complex non-class signature, interferon gamma signature, and then T cell inflamed gene expression profile, which they call GEP signature too. A lower proportion of the TME type 1. TME type 1 basically has a really high PD-L1 and CD8 ratio. They saw further decreased immune inhibitory checkpoint molecules as well. These specific ones also correlate with CTLA4 and PD-L1. And then poor correlation of that PD-L1 expression between the paired samples. So once they metastasized to the brain, we didn't necessarily have the same PD-L1 expression that they had in the extra CNS compartment. So there are a few clinical trials of interest. This first one here we are opening. This is NRG-BN007. So this is a randomized phase 2 and 3 open label study of Ipi and Nivo versus temozolomide in patients with newly diagnosed MGMT unmethylated glioblastoma. So unmethylated glioblastoma patients have a worse prognosis. They have less sensitivity to temozolomide and do poorer overall. So this is a good group to look to see if we can improve upon that. So other clinical trials of interest that will be elsewhere in relation to some of the things that we saw at ASCO. So safety and efficacy study, I can't say this word, retifanlimab, I believe, and epagodostat. I don't know what the shorter name for that one is, in combination with radiation and bevacizumab in patients with recurrent glioblastoma. So this one is an IDO1 inhibitor. I mentioned that earlier. So IDO1 inhibitors promote tryptophan catabolism, which then once that's depleted, you have suppressed T cell and NK cell function. This is overexpressed in 50 to 90% of glioblastoma patients, this IDO1 is. So it correlates with reduced overall survival, and this specifically, again, is an IDO1 inhibitor drug. They're giving it with a humanized anti-PD-1 monoclonal antibody, this one here, this retifanlimab. Specifically, they're also looking at bevacizumab naive recurrent glioblastoma patients are going to be eligible for this study. They'll be randomized to the retifanlimab, bevacizumab plus radiation in cohort A, and the same treatment plus the IDO1 inhibitor for cohort B. Last one I want to mention is Luminos 101. So this is a phase 2 study of PVS repo. So this is what many of you may know of as the recombinant poliovirus rhinovirus chimera that is going to be with pembrolizumab given in recurrent glioblastoma. So there was a single-arm study of an intratumoral infusion that was a phase 1 study initially that looked quite promising, and that's why this has been done. So that first immunotherapy study with monotherapy PVS repo infusion showed 21% of patients in that cohort were still alive at anywhere between 36 and 60 months. So up to 5 years, very, very good, promising, exciting, but again, only a phase 1. When you look at criteria matched external controls, again, we don't see nearly as many patients make it to 3 and 5 years. So that promoted this single-arm study of intratumoral infusion with PVS repo that's going to be followed by pembrolizumab. For infusible disease, recurrent glioblastoma has to be between 1 centimeter and 5.5 centimeters of enhancing disease. So those patients will be the ones eligible for this. They're looking at induction of type 1 interferon dominant inflammation as one of the sub-studies, and they're also looking at activation of the PD-1 to PD-L1 immune checkpoint pathway too. So in conclusion, the CNS is not an immune privilege site that we thought it was many years ago. There is proven crosstalk between the CNS and the peripheral immune systems. Tumor microenvironment does differ in matched brain metastases samples, which I think we can learn some lessons from, knowing that there's less of an immune effect going on in the brain for metastases as well as our primary brain tumors. Biomarkers that correlate with success of checkpoint inhibitor therapy and other tumors do not hold true in glioma. Glioblastoma has both innate, adaptive, and acquired resistances in the anti-tumor immune response. Most likely, any successes are going to require a multimodal approach. So that would be neoadjuvant therapy, working with our surgeons and our timing of checkpoint inhibitor therapy, combining different checkpoint inhibitor therapies with radiation therapy, and even considering dual inhibitor since we have more than one pathway active in most of our tumors. Thank you very much.
All right, Nicole, thank you very much. That's always very, very thorough, very interesting talk. Although I guess the result is still disappointing, but we're seeing hope here. All right, so we're running a little late, so let me get started.